to learn, but it's just for you to have some idea of how they know what age children are by x-rays. One of the things that you worry about are injuries to the growth plate. And here's a site that kind of goes in a little bit more about that. But long bones have growth plates. And I'm not sure, that's definitely a mistake. And at the end of each one of these bones, there's a separation between the epiphysis and the diaphysis, or the shaft of the bone. And these little openings allow blood vessels to penetrate the epiphysis and keep it alive. So the entire growth plate there is weaker than the rest of the bone. So in the growth plate, this is where you get your cartilage cells and dead cells removed, and then the matrix is converted into bone. So if there's damage here in the epiphyseal circulation by growth plate injury, then they don't produce the chondrocytes, they don't produce the cartilage, and the bone's not produced, and the growth of the bone stops. So that's a critical thing for little kids. So here's a diagram illustrating that. You can see where the growth plate is, and there's lots of vessels that supply the end of the bone. So bone actually grows laterally and longitudinally. It grows thicker and longer just by piling on the bone in layers. Important points to remember. Longitudinal growth occurs from ossification centers in the growth plate, whereas width and strength takes place via intramembranous ossification. New bone is deposited on the periostal surface. The apophysis sites are where the tendons connect to the bones, and these sites can be overused or get inflamed, such as Osgood-Schlatter disease. The development of muscles and bones is influenced by use, so it's true if you don't use it, you lose it, and if a limb is not used, it doesn't grow very well. And so this is why exercise for young children is so important, because it does help stimulate bone growth. And then muscles, if they're not used, of course, go into contractures. And so exercise for young children helps put them through the full range of motion. The musculoskeletal disorder is symptomatic of...
Oh, I'm sorry, you're going to start that, never mind.
No, she's fine. You're going to have to mute yourself there because you're picking up family.
We're all coming over Friday, right? You guys know it?
Can we mute? You guys going to do that? So if you look at those are some conditions when you see them in the clinic that you need to think that bones may be involved or muscles may be involved. Those are some things for you to think about. Here's an example of a genetic problem. There are some genetic problems that can cause musculoskeletal problems, and the osteogenesis imperfecta is a genetic problem where whenever you just change diapers, you can actually break the bones from just minor trauma. And this patient has decreased levels of collagen. And so sometimes they are very small because they've had repeated fractures of their bones. Down syndrome, you can see this little boy's hand. I tried to get a really good picture of this, but they have very loose joints and muscle tone, so they can bend in ways that the usual people cannot. Other genetic problems that are associated with musculoskeletal are Down syndrome, so the leg calf-perthes, which we'll talk about, patella instability, where you have the subluxation of the kneecaps, flat feet, pes plenis, Marfan syndrome, they have low muscle tone and lax joints, and can have dislocations, and then a neurofibromatosis or Turner syndrome can have scoliosis. So when you see these conditions, you just need to think about that you could have some musculoskeletal involvement. So the Noonan syndrome, and I did manage to get a good picture of a person with that. They have a webbed neck, which you can see on the picture, pectus carinatum, which is the pigeon chest, or they can have a caved-in chest. They're clumsy, poorly coordinated, and they have motor delay. So they would not be walking and running and those kinds of things like your average child. Then you can also have problems in utero from compression that would deform you. So if there's like 5 little babies in there, there's not going to be room for all of them, or if even twins sometimes crowd each other out, or if you have reduced fluid as a mother, then this is going to crowd the baby. Fortunately, most of these will return to normalcy. However, the longer that is a problem, the less likely that is going to be the case. Orthopedic injuries, clavicle injuries are usually seen whenever a child falls on outstretched hand or by direct force. And it usually, as you see here, involves the middle third of the clavicle. These can be seen in newborns as well. They can have pain with shoulder movement, not be able to move their arms on that affected side, or when they have a Moro reflex, only one hand can go up. So you actually can see some swelling and discoloration, even crepitus you can feel over the fracture site. So it doesn't take long for the callus to form, and so you may feel a little lump there. So it may or may not cause pain and may or may not need treatment. But you can actually immobilize the little baby by pinning the sleeve of their arm on their shirt to the front of the shirt for 1 to 2 weeks. And for the older child, they oftentimes use a figure 8 sling. So what do we see what in? So this gives you another way to diagnose. Swimmers and people that do throwing motions can have tendon problems. Dancers, gymnasts, and figure skaters oftentimes injure their ankle. Shoulder can come from overuse, like if you're a softball or baseball player, or even if you do volleyball. Dancers have trouble with their hips. The prostatitis is an overuse injury unique to skeletally immature active children or athletes, and so they have irritation, inflammation of their muscles and ligaments and tendons and bones. So all of these kinds of folks would be coming to see you in your clinic. So there should always be in the back of your mind a high index of suspicion in fractures for non-accidents, where the injury is unexplained, Are the severity of the injuries incompatible with the history that you're hearing? Or it's incompatible with what the child is able to do? Rib fractures or any unexplained fracture younger than 3 years of age is problematic. Remember that the most abused children now are under a year of age. Fractures in the middle of their legs or multiple fractures in various stages of healing or a complex skull fracture. Remember, babies' heads are very large, so if something is going to be hit, it would probably be the head. I can tell you that we had one family, there were 3 children in the family. The baby came in, the older boy had a fracture. Not long after that, the baby came in. The baby had a broken arm, and the mother said that it was due to the 2-year-old. Shaft fractures, you can have torsion of the foot. This is where you have an oblique fracture in the tibia without the fibula being fractured. And this would be something you would see if the baby or the child was tripped when they were walking, or they stepped on a ball, or they fell from a modest height. They will fail to bear weight, limp, it hurts. And when asked to stand, they don't because it hurts. So the treatment here is immobilization. Another shaft fracture you might see is where they fall on an outstretched hand. This can cause fractures of the forearm, usually a green stick fracture. So you look for swelling and rotational deformities, check for neurovascular involvement, and compare the 2 limbs. So you need to get always an A&P lateral and oblique views if you think there's a fracture of the wrist and the forearm. And sometimes you have to think about x-raying the joints above and below the fracture. Because failure to diagnose here, the child will grow up and not be able to rotate their forearms if you don't find this for them. So what do you need to assess for a musculoskeletal system? Well, the history for sure should include, like, when did it start? What kind of pain level do you have? Is there any deformity? How did you injure it? What are you not able to do? And then to watch the child walk to see if it's a hip problem or a lower leg or foot problem. What kind of medicine have they used? Do they have a family history of any kind of genetic disorders that might be seen in the musculoskeletal system as problems? What's their medical history? Have they had multiple fractures before? Developmentally, have they developed like they should? And then to review the systems to see if there's any problem there. And the specific questions in burns are on page 1046. I didn't include all of them here, just the major ones. Okay, so for the physical exam, what are you looking for with regard to the skeletal system? You're looking to see if the area is swollen, red, if there's any bruising or pigmentation there, anything sticking out. If there's like a shoulder injury, you want to hold your hand as you put through the range of motion to feel for crepitus. Are the two symmetrical? And do they both have sensation the same? And you can do the tendon reflexes, feel the temperature of it, check for capillary refill, tenderness, and prominence. So there's a lot of things to look for. So you put them through, if they can, the range of motion. Can they actively do it? If they cannot, then you can actively do it to kind of gauge where the problem is. Watch them walk, because by 3 they should have a normal gait. So you compare how they're moving their arms, their legs, inspect them from front, sides, and back. and the gait should be smooth and rhythmic and efficient. So there's two kinds of limps. There's the antelope limp, which is seen when there's a single limb stance phase is shortened. So when they're on one leg and they're moving from one leg to two on the ground, that's going to be lessened, and they do that so that it doesn't hurt. Then the other one, the other type of gait is just weakness or spastic or muscular disorders or leg length discrepancies. So the Trendelenburg gait is when where the trunk tips over the affected hip. And I think somewhere I've got that where you can see it. But there are special examinations to do for musculoskeletal problems. There's the Galati maneuver where you flex the hips and knees while you've got them lying on their back. You place the soles of the feet on the table near the buttocks, and then you look at the knee heights for equality. So you're just checking to make sure that the knees are the same heights and they don't have one leg shorter than the other. And you should do this with newborns. When you do the newborn or infant checks, you should do these. The Barlow maneuver is again where you place the baby on the back with the knees flexed, the hip is flexed, and the thighs brought into an adducted position that's away from the body, applying downward pressure. And you do this one at a time with the hips. And if the dislocation is there, you should be able to feel it. The other maneuver that goes along with that is the Ortolani maneuver, where you place the child on the back with the knees flexed. You've probably seen in the clinic your providers doing this. The thumb is placed near the trochanter and the pad of the second finger on the bony prominence of the greater trochanter. So you flex the leg at the hip, then abduct it, moving it away from the body, pushing up with the fingers, and you should be able to hear a clunk, not a click. A mild click is not considered a positive sign. So there are some YouTube videos. I knew I had YouTubes for you, so there's some YouTubes there where you can see how that really works. Another test is the Clistic test. This is where a tip of the third finger of one hand is over the trochanter, like you see it there, and the index finger of the same hand on the anterior iliac spine. So you draw an imaginary line between the index and third fingers. Normally this points to the belly button. If it's below the belly button, then the hip is dislocated. I've never really seen anybody do that, but I do know it's, one of the tests that you can use. The Trendelenburg sign here is a YouTube. I knew I had some videos for you. Here's a YouTube that you can click on. You have the child stand and then raise one leg off the ground. If the pelvis drops on the raised leg sign, the sign is positive and indicates a weak hip abductor muscle on that side that is trying to bear the weight. Normally, the muscles around a stable hip are strong enough to keep the pelvis level. And so the YouTube shows you how that works. There's medial lateral rotation, so you place the child prone with the knees flexed at 90 degrees. So they're laying on their stomach with their knees flexed. Medical rotation is measured as the legs are allowed to fall apart as far as possible, and they should be able to do this 45 degrees, both internally and externally. They should be able to fall apart. Back exams, I know that you've been doing probably a lot of these in the clinic. It's called the Adams Forward Bend Test. So most people just call it scoliosis check, but that's the official name for it. And what you're looking for is unequal shoulders, unequal hip height, a rib hump, If you're present, you can use a scoliometer, and here is what that looks like. It's much like if you've done any carpentry work, it's much like a level when you're trying to get things straight. So if it's greater than 5 or 7 degrees on the scoliometer, then they need to be referred. And you can see that on that YouTube site that's on that slide. So the diagnostic test that you would use would be an A&P lateral x-ray. If it's a fracture, you think it's a fracture, an oblique view is always good to use because you can miss some fractures without the oblique view. You need to maybe view both extremities for a comparison of the two. CT scans if you think you're dealing with a lesion. MRI if you think you're dealing with a joint. Ultrasound if there's a cartilage or tissue problem of the hip. Bone scans if you can't figure out why they've got skeletal pain. But all of these you have to weigh the risk and benefits related to radiation for children. Because they're so little, it's not good for them to have a lot of x-rays. Laboratory studies. Most of these studies either would rule out an infection or some kind of inflammatory process. So those are all good. The SED rate is good for inflammation, the creatinine protein, and the complete blood count and blood cultures. All of those are good for infections and inflammations. The rheumatoid factor, the anti-nuclear antibodies, ANA test, those would be good for your inflammatory systemic conditions. I have never seen anybody order these muscle metabolism tests. I'm sure probably specialists do, but I've never seen a primary care do that. And I've never seen them do biopsies either in the primary care setting. They usually don't. So with regard to management strategies, counseling to the families and the child about what causes it, what it is, how you plan to treat it, what's the prognosis, are there any genetic implications or long-term issues with these problems. Explain that some of them will right themselves, and it's always good to tell parents this, that the flat feet of infants and toddlers will straighten out once they begin to walk. The bow legs in toddlers and the knock knees in preschoolers, they will in all likelihood go away. So it's always good to tell the parents that so they don't think that they have to, be referred. Features of a good shoe for children should be flexible, flat, shaped like their foot, have at least a thumb span at the end of the foot. The friction should be similar to skin so that it's not so big it runs up and down on their heels. If there is a difference of more than 2.5 centimeters, they probably do qualify for having a lift in their shoe. You may be able to cast and certainly able to splint children in your clinic. This is usually used to mobilize it, protect it, actually reduce pain, and help compensate if the muscle is weak. Splints are not as likely to cause compression injuries because most of the time they're not all the way around, but casts are circumferential immobilizers, so they're all the way around and should only be used for a short period of time because of the muscle atrophy that you can get from just having a cast on for any great length of time. Tell the parents to clean it with a damp washcloth and keep it cool and dry, and if it happens to get wet, to use the hairdryer on the cool setting, not the hot setting, so that you're drying the outside but not the inside, where it will mold. Teach the family how to do neuro and circulation checks. Remember, these things itch. If you've ever had one, you know that for sure. And the way children scratch is by putting things down in it. So using your nose to smell is always good, because when they put stuff down in there, they excoriate the skin, and then they get an infection and all kinds of trouble. They should be able to feel all of their fingers and toes and be able to wiggle them. Call if their fingers or toes are cold to touch and appear pale or blue. If they're complaining of tingling or numbness, they can't move it, or there's a lot of swelling, or it stinks, or it's broken or loose, then they need to call you or whoever put it on them. After the cast and splint removal, the family should be taught to soak and gently cleanse the skin, pat it dry, but avoid rubbing it to get the excess skin off, because you can cause some excoriation. Here is a typical thing that you see parents do a lot. I know you've seen this in any mall or any place outside where the parents are grabbing the children's arms and the kid thinks it's fun, but actually it can cause subluxation and dislocation. It's called an annular ligament displacement, or a nursemaid's elbow, and it's frequently seen in children 6 months to 5 years of age. And in fact, after it happens, the child oftentimes cries. They refuse then to bend their affected arm, and if you try to move their elbow, it hurts. They'll, in fact, put that very close to their body so that nobody's bothering it. And if you know what causes it, then you don't have to do an x-ray necessarily. But you can actually fix it if you're experienced in doing this. And here is the video for how to fix the nursemaid's elbow. You approach the child in a non-threatening way and distract them. Then you use supination and flexion, or the pronation technique, and you can see the video for how to do this. If there's epitropial tenderness, do not do this, because they may have a fracture, and so you'll want to, in that case, get an x-ray. But there's a good video for you to watch about how do you fix a nursemaid's elbow. Physical exam with when they come in, you can have a brachial plexus injury, and here's a picture of a brachial plexus. This can occur from breech bursts, very large babies coming out even normally, older mothers, or something disparate in the pelvic anatomy, or if the mother's obese and has diabetes, if they suctioned the baby out or had to pull on the head or shoulder, then you're going to stretch the cervical nerve roots and they're going to be damaged. When you examine these children, they have an adducted arm, which is internally rotated at the shoulder. The wrist is flexed and the fingers are extended, much like a waiter's tip posture. There's asymmetric moro and tonic neck reflex on their affected side, and even the wrist and hand can be limp with no ability to grasp. There are things called Horner syndrome, where you have this with ptosis and meiosis and inophthalmos and anhidrosis because of the damage, ruptured livers and spleens, and limited neck movement, or even impaired respiratory effort. So this will need an x-ray and an MRI probably, and it really needs a lot of people involved other than just you. So this is a referred child, and surgery is usually done in the 3 to 6 month age span. So here it is, a little kid with what we've been talking about. This child has Erb's palsy, and you can see the deformity in the arm there. It can be bilateral. This little kid, it looks like, only has it on the right side. So when you're going to lift children, you do it under their arm, so you don't get the nursemaid thing I forgot to mention. You never lift them with their arms, but under their armpits. Chondritis is another problem. Your textbook mentions the Tsetse syndrome, which is the presence of pain, swelling, and tenderness of the costal cartilage. I just put that in there, not you have to memorize that, but if you ever saw it, you're like, I have seen that word before. But this is inflammation of the costal-chondral cartilage, and oftentimes children will arrive in the clinic because of chest pain. And if they've been lifting heavy objects or coughing a lot, you might see this is one of the histories. So here is a Jessica, 14-year-old, that presents to the clinic with chest pain, which is of sharp, darting quality, exacerbated whenever she deeply inspires. She just recovered from an acute asthma attack, which lasted longer than expected, so she's been coughing a lot. When you palpate her anterior chest, you notice that she is sore and tender over the 2nd through the 7th rib cage. Besides tenderness, she also has some swelling, but her heart and lung and abdomen sounds are all normal. She has no cardiac history, no personal history, so you decide to treat her with NSAIDs to relieve the discomfort and give her a cough suppressant, and you get a follow-up on her in 2 days if she's not improved. So it's not unusual for this to occur in your clinic to see a child with costochondritis. Back pain, when is it serious? This is a very important thing to know. The younger the child, the more serious, you need to think about. The older one, it is probably musculoskeletal in origin. But any young child that has these symptoms, or older ones that have some of these symptoms, is serious. Most back pain is just from strain, but it can be a serious issue, especially if the symptoms persist or they keep the child from doing what they need to do, or wake them up at night, or there's other symptoms along with it, or they've got some weakness or problems in reflexes, or history of TB or cancer. If they've had cancer, for example, of the liver or whatever, and then they start having back pain, and you worry that the cancer's gone there, or if they have lost weight for no good reason. So what are you going to find? Well, you need to know their history, of course, all the usual stuff for history, and what aggravates and relieves it. If it is in the morning or after they've been at rest, it's usually due to an inflammatory cause. If it's back pain with activity, it's usually due to a mechanical problem. School-age children, all of a sudden, may go to phys ed, and they've been used to being sedentary, and so all of a sudden they're increasing their activities. They may have back pain. Those muscles don't know what to do with exercise. Or if you have a young girl that started wearing high heels or platform shoes, or if you have children that stay at the computer all day long or watch the videos. So you need to perform complete musculoskeletal neurological exams with palpation and examination of leg length. So those are any changes in bowel and bladder habits or disturbances in gait or altered sensations would also be things to be concerned about. Diagnostic tests, there are, again, very similar to what we've already talked about with regard to the diagnostic tests before. Management of back pain. You have to rule out that there's problems with the disc or that the bone is infected. Like if you had a child that had impetigo, you would be worried that the skin infection's now gone into the bone. So that's always a problem. Children do have tumors of the bone, so you'd have to worry about that. Whether they have stress fractures, you know, if they've done something to themselves to really cause a stress fracture. You have to also rule out that they don't want to do something, and so to get out of doing something, they say they've got pain in their back or in their legs when really they do not. Any pain like that lasting more than a month probably needs a referral to a specialist. And if it's due to something they've done to hurt themselves, you might want to send them to pain management or to physical therapy. Here's case number 1. Sam is a 6-year-old who's getting ready to attend school. He is at your clinic for a school physical. This is his first exam because he's not been to the provider due to lack of health insurance. It appears that he has some slight neuromuscular symptoms similar to cerebral palsy, as he has some spasticity noted by his gait. His family history is negative for muscular dystrophy, but he was an at-home birth with some delay in breathing on his own, which probably accounts for his symptoms of cerebral palsy. His mother complains about his pants, which she says she can never get the hem right. It always sags on one side. What clue did the mother give you? The clue that she gave you was that his hem on his pants always sags on one side, which would maybe alert you to the possibilities for scoliosis, which is common in children that have that spastic form of cerebral palsy. So you evaluate him from the front side and ask him to bend over. You do the Adams forward bend position. You notice that his shoulder height is unequal, the scapular prominences are unequal, his hip touches one arm while the other hangs freely, there's a rib hump, and the heights of his hips are unequal. You can see what the mom sees in his pant lengths as well. And what does he have? He has scoliosis. And here is case number 1 continue. This is the little boy. You use your scoliometer, and it looks like he has a curvature of 15 degrees. You order a standing AP and lateral x-ray, and he has a right thoracic curve, no kyphosis, which is hunchback, or lordosis, which is swayback. We know that it was not a functional problem, as bending forward did not make it go away. Now that you have the diagnosis confirmed, what are you going to do? Well, you're going to refer him. That's what you're going to do. You can tell he has pretty bad scoliosis, and observation's good if it's less than 20 degrees, but this little boy, honestly, from the picture, looks like it's more than 20 degrees. So 30 degrees or more, they might have to put a brace on him. However, you doubt, based on the history, that they're going to, this family, have a support enough to wear a brace 23 out of 24 hours. He's also one of several children, and the mother lost her husband in the Afghan war, so the mother's overwhelmed. If the curvature was 45 plus degrees, he might be a candidate for surgery. That would have had to occur with the help of the Shriners. And be sure and read about the newer procedures that are being done on page 1059. There are awesome developments occurring with scoliosis. It used to be a really bloody surgery. The things that they have to wear are very uncomfortable, and they're noticeable. So the newer treatments really look really promising. So which is lordosis and which is kyphosis? With kyphosis, there's an AP forward curve of the thoracic spine with the back being prominent. In older children, this can be related to poor posture or heavy book bags. If it's over 50 degrees, it will require surgery. Otherwise, any activity that requires full range of motion is recommended. Lordosis is an AP curve of the lumbar area of the spine and can be secondary to scoliosis or a hip problem. If a child bends forward and the lordosis disappears, then it's physiological rather than structural. If it remains, when they bend over, it's fixed, and you need to refer them. So on all of these, if any of these disappear when they bend over, then it's probably due to something other than a structural cause. So the little guy on the left has lordosis, the one on the right has kyphosis. Okay. Case number 2, Susie's a newborn who was delivered by breech and has been examined by you in the nursery. Her mother had oligohydramnios, and it was thought that Susie might have to be delivered by C-section. However, she came earlier than expected. You find that she has unequal gluteal folds, lack of ability to abduct her right leg more than 60 degrees. Her legs are of unequal length, but she is experiencing no pain. What does she have and what contributed to her problem? Well, she has a dislocated hip on her right side. And what contributed to that? Probably the mother's lack of amniotic fluid. What in her family history would have been important if any other family members ever had this? And what would you do any type of diagnostics now? Well, you won't be able to see anything till she's about a month old, so you could do an ultrasound then, because she might have something that would show up. And what is the plan of action? Refer, refer, refer. You cannot fix this. Here's a harness that's used for children with dislocated hips to push the head of the femur back into the acetabulum. Most resolve by 6 or 8 weeks on their own, but it's good to use this harness. If it doesn't work, then they have to have surgery, and they have to wear the harness for 24 hours a day except for baths. So you would get them in every week. And then by the time they're 6 to 18 months of age, they may have to have surgery, and this is what a child looks like. After surgery, they're placed in a hip like a cast. Doesn't look like this bothering this little girl very much, does it? Case number 3, Bill is a 4-year-old who's begun to have an intermittent limp, especially after exertion. His pain is in his groin, and at times he's referred to his anterior thigh and ipsilateral knee as hurting. He's at antelope gait with limited hip movement. His Trendelenburg gait is due to his hip pain. Upon exam, he has decreased abduction, internal rotation, and extension of the hip. Upon a routine AP pelvis and frog leg lateral x-ray, what do you think you would find? This is a classic case of a little boy who has leg calf Perthes disease, where the bony epiphysis of the femoral head has been infarcted, a lack of blood supply. So it's really an avascular necrosis of the femoral head of his hip. Eventually, the bone will reossify, but the problem comes if you apply pressure to that leg, then the head of the femur will be flattened and you'll have one leg shorter than the other one. So they usually will try, here's an example of what they'll do. They'll try to limit weight bearing, by bracing the hips, and so they have to be in that for an extended period of time until the head of the femur begins to reossify. Case number 4. George was a 13-year-old African-American boy who was seeing you in the clinic to evaluate his weight problem. He had been through all the endocrine tests to determine if his weight was associated with abnormalities in that area. Today, however, he had the assistance of his mother because he started to limp. He eventually admits that his hip, groin, thigh, and knee hurt. His mother says that he only turns his toes out on that one side when he is walking, and he's never done that before. While he can externally rotate his right thigh, he has limited abduction and extension. He says weight bearing hurts him. What do you think he has, and what are you going to do for him? He's overweight, African American. What he's got is flipped capital femoral epiphysis. So actually the head of the femur starts sliding out of the acetabulum. So what you do, again, refer him to a surgeon, no more weight bearing, and you can see your textbook for a really good picture. They have a really good picture of this in your textbook. So which one of the two figures on the right is genu valgum or genu valgum? These are bow legs and knock knees. Valgum is the right one and valgum is the left one. And if these present after age 2, you need to refer. And knock knees, which is the left one, usually disappears by 8 years of age, and you can see this little boy is braced to try to help that. Case number 6 is Orlando, an adolescent who's been running track at the beginning of the school term. He's been putting his heart and soul into making the first start. He is coming to you today because the warm-up exercises where he squats is hurting him on both knees. He's beginning to hurt when he runs as well, but it subsides once he rests. His knee area feels warm and looks swollen. He says it hurts whenever you press on it. What do you think he has, and what are you going to do for him? He has Osgood-Schlatter's disease. We mentioned that earlier, so you need to have him avoid activities that cause pain and inflammation until the pain and inflammation goes away, so you can put ice and cold therapy there. Then he needs to do some quadricep stretching exercises to avoid this from reoccurring. And you can, as you can see there, put a knee sleeve over the tibial tuberosity to kind of help support it. So for 2 or 3 weeks, he needs to not do weight bearing, and you can, if he's involved in like soccer, he may need knee pads so that he doesn't re-injure his knee. Case number 7, Jesse's a child who toes in, and Mary is a child who toes out. What is responsible for toeing in and toeing out? 3 things can make a child toe in or toe out: the hip, the tibial bone, or the metatarsus. Those are 3 areas that can cause problems with toeing in and toeing out. Most in-toeing resolves on its own by 8 years of age. Why is that? Because over time, the feet naturally on everybody turn out. So if you start with them out, they're going to be even more out by the time you get to be an adult, because the tibia normally rotates outward over time. There are some examples in your book of how to assess for the feet and the thighs, viewing them directly from above. But you can watch in the clinic, you can watch a child walk, you can look at how their shoes wear. Depending on whether they're toeing in or toeing out, the shoes will have a different wear. Even the back heel of the shoe should wear in the middle, and if it doesn't, then that's indicative of toeing in or toeing out. So if it's more than 20 degrees by age 3, you would refer. So it's always good to know. You should try to memorize the ages when it's a worry and when it's not. Case number 8, Alice is a 15-year-old complaining of swelling behind her knee. What knee conditions are you going to rule out? Well, one of the things that you want to rule out with this child is a popliteal cyst, which should resolve in 20 months at the longest, and ice and NSAIDs will help. But this is not an uncommon condition. Case number 5, Tony was rejected for the Army by pes planus. What is that and what is the treatment? That is just flat feet, and usually by age 3 it resolves. If it's flexible and it disappears when it's suspended and you can see the arch, then that's a benign condition. And when that happens, you know, when you get back on your foot again, you're going to have a flat foot. But if it's still flat when it's raised up off with no weight bearing, then that is a fixed flat foot. You can see if it will help to have an arch support. If the Achilles tendon is tight because of it, then they might need some stretching. But this is a very good picture of a flat foot. So when you're in clinic, you can see there's no arch here at all. And so here's how you can see a high arch, or you know how it's supposed to be right in the midline, and then a flat arch, and what happens to the Achilles tendon and why it might be stretched. A good picture to show that. So for metatarsus adductus, where it goes toward the body, here's some shoes that'll kind of help straighten that out with regard to the forefoot relative to the hind foot. And you can do some foot stretching exercises. And when you do those, how you know you're doing them well is that the foot blanches. Let me shut the door. My family's arrived back home. So if there's no improvement, they'll do serial casting. So they'll cast and then, you know, try to get the foot straight, and then maybe even, you know, eventually have to have like surgery or these corrective shoes. So here's a good example of metatarsus adductus where the foot's turning in toward the body. This is A on the left before the surgery and B on the right. And usually they delay it till about somewhere between 4 and 6 years of age. Here's club feet where they're totally twisted. Calcaneal valgus is where they're twisted on the out, toward the out, that would be on the left. Equinovarus is where they're twisted inward and downward. So this on the left is up and out. Equinovarus is down and in. And talipes goes in front of all those words and just means referring to the ankle or the foot. So you refer as soon as possible for this, for castings weekly, and then they may have to do surgery, and they may have to be in braces up to 5 years of age. So, pretty serious thing. Toe walking, you need to know, is normal until 6 months of age. This is especially true if they've used a walker. They may keep toe walking until they're 3. It can be seen with cerebral palsy because of the tight Achilles tendon. So you want to measure their leg length to make sure that they're the same on these little characters. Ganglion cysts, you might see these arise in the joints. Some of you may have had them yourself. They're hard, fixed masses. They're usually found on the wrist or the flexor surfaces of the fingers. You can take an otoscope and actually transilluminate them, rest, splint, and sometimes you have to have surgery for a ganglion cyst. Leg aches. A lot of kids have leg aches. They have growing pains, usually at night. By morning, they don't have the pain anymore. It's usually somewhere between 4 and 8 years of age. Usually, nothing serious here. It is a diagnosis of exclusion. So you ask them, when do you notice it? They, of course, do not notice it during the day because they're busy playing. They only notice it at night. It is always in their long bones, never in their joints. Pain in joints in children is a very serious problem. Pain in the long bones just means their muscles are getting stretched for the most part, unless you can feel a mass. So refer if the pain is localized in one spot. If they're swollen or they have constitutional symptoms, then that would not be just plain old growing pains. The limps, be generally familiar with the causes of the limps. You do not have to memorize the entire chart, but you ought to know what causes a limp, what some of the causes for limps are. Do I have any questions for me? Any questions, anybody, about the musculoskeletal system? I'm glad to be with you tonight. Sorry it couldn't happen last night.
Can you hear me now?
Any questions? You can either type them or use your microphone if you have them. Okay. All righty. Hearing no questions, then I guess we'll call it a night. Thank you for being with me.
Thank you.
Can we ask a question about the study guide? You can ask a question about anything you want to. What's your question? You can type it in the chat box if you want to. Probably somebody else has the same question. You see the chat box at the bottom? You can type your question in it. For the first question of the study guide, under what? Under what? I didn't see all the questions. Okay, are we supposed to know the difference between neonatal and fetal circulation? What you need to know is what happens once the child is born. What's changing? What structures are going away? And what's happening to the blood? When they were in utero, the mother took care of blood. Once they're born, they're taking care of their own blood circulation. So what's made the difference there? You need to be able to know that. I don't expect you to trace the blood. I'm not going to ask you to trace the blood. You already had that in anatomy and physiology. So what I want to know is what's the change in the shift, what structures are closing, what difference does it make if they stay open? Did that answer your question? Oh, yeah, okay. So this means before birth and after birth. Any other questions? I'll take them on anything. This is a great time to ask them. That was my main question. Sounds good. Anybody else? Any questions about athletics and abuse on the test? If it's not on the list, no. The test will come from the list I gave you. Anybody else? It'll be pretty much the same as the first test. You got the same person making them, so they should be pretty much the same. Did I miss the study guide? I did send it out. I can send it out again. It was just a list. I think it's 50 or 51 items I sent you all via the email. But I'd be happy to post that again. Well, if you don't have it, Jonah, just email me and I'll send it to you. I think it was in your email. Did anybody else get it? Anybody else not have it? Everybody else got it? So check your email. If it's not there, let me know. I know things get lost in the email. I know they do. They get deleted or go to spam. So things happen. Any other questions, you guys?